Good morning. This is Dottie Howe, Communications Director at the Ohio Health Information Partnership, also known as the Clinisync Health Information Exchange. Thank you so much for joining us this morning for Meaningful Use in 2014, the Flexible Reporting Option. Today's webinar is also co-sponsored with the Central and Southern Ohio chapter of HIMSS. We're happy that you're all with us, and I'm going to turn this over to Scott Mash for just a moment. Thank you.
Hi everyone, my name is Scott Mash. I'm the Operations Manager here at the Ohio Health Information Partnership. I also serve as the Vice President for the Central and Southern Ohio HIMSS chapter. Before we get started on the webinar today, we wanted to talk about the HIMSS chapter for a little bit. We do have a new website for the CSO HIMSS. As you can see, it's http://csohio.himsschapter.org. If you go to our old URL, which is www.csohims.org, it is auto-forwarded over. We also have a couple new email addresses that you can see there on the screen, csohio.president@himschapter.org. We'll go to our current president, David Kissinger, and the csohio.info. That one goes to a few of the other board members, and if you have any questions in regards to the chapter, please feel free to email either of those. We also have our fall conference coming up on October 24th, which is a Friday. The conference will be at the University of Cincinnati Drake Center. You can register at the link on the screen. It's a pretty long link. You can also go to the eventbrite.com website, and if you just search for CS Ohio HIMSS or CSO HIMSS, you'll see our event there, and you can register. Right now, the conference is titled Data, What Is It Good For? We've got a very strong agenda for the day, and we're expecting around 200 folks, so please sign up as soon as possible. And I'm going to turn this over to Kathy Costello, who will cover the first part of the of this webinar, and then I will be talking to you again here in a little bit.
Before Kathy starts, I'd just like to tell you, this is Dottie again, that you will be receiving from me after the webinar a PDF of the PowerPoint itself. It's large. If you need the slides, email me back and I'll send you the actual slides. There's also going to be some documents that we'd like to share with you. Kathy will explain what they are. At the end of our webinar, after their presentation, we will be leaving a lot of time for questions. So I want you to go to the chat button on your screen, and as they're talking and you think of questions, please feel free to put them in, and we will answer every question. So thanks again for joining us. Kathy?
Good morning, everyone. Thanks so much for being with us. Let me just say that we are not going to take a break at 8:46 to remember the 911 victims from 13 years ago, but we do ask you to keep their families in your prayers and thoughts. Okay, let's see, thank you. All right. What we're going to cover today is the rule that many of you were familiar with that was released as a proposed rule in May and was finalized last week on September 4th. And it does include all the points that were discussed in the proposed rule, but does have other sections that were added in, which actually made the final rule 3 times as long as the proposed. So I think it's worth noting that because there are many issues that are addressed. Let's just say, to set the stage with why the rule was proposed and where we're headed with 2014 filings, is that the overall picture in 2014 was, by the time we got done with all the 2013 attestations, there were 350,000 unique providers who had attested. So you were looking at 350,000 providers and their various practices or hospitals that were required to upgrade to 2014 certified products in an extremely short period of time. The vendors on their part the Stage 2 final rule had come out in 2012, and so in order to get certified to provide their systems to the providers, they literally had really, I would say, less than a year, or just about a year, to do all that, build and upgrade, and then go through the certification process. On top of that, CCHIT, who had been doing about 2/3 of all the certifications for the CMS ONC program, decided last February that they were no longer going to participate. And so what was already a strained system became overly strained, and many vendors were late in getting their certifications. Some still are waiting for it. So this kind of gives you a picture of why the rule was put out. Let's just give you a real quick snapshot of where we are as a country with Stage 2. There have been 8,000 providers, and well, 8,500 if you count the hospitals, who have done any attestation in 2014 as of a few weeks ago. Of those, 3,000 EPs and 143 hospitals have attested to Stage 2. So it is a low number. I think this does reflect some of the both certification issues and adoption issues with the technology. So as I said, I know all of you, we're out there in the field so much. I know all of you are grappling with similar issues, and so hopefully this rule will help you work your way through to be able to attest in 2014. Let's talk about what the rule does not do, because I think it's very important that people understand how the attestation process is to work in 2014. The rule did not change the timeline for attestation in 2014, or for that matter in 2015. And I think that's important to note, because there were over 1,100 comments came in to CMS about this rule. And I think a high number of, at least the big organizations, had suggested extending timelines, but this was not done. So it is very important that you keep your attestation process on the same timeline. And what is changed under this rule is how you do attest to meaningful use, but your timeline must be the same. So for hospitals, if you have not attested yet, you are in your last phase or possible attestation period for 2014, which is July 1st through September 30th. You then have until November 30th to finish your attestation at the CMS and Medicaid websites. For physicians and EPs, if you're Medicare, you will still be required to attest by quarter in 2014. So it does not have to be the last quarter, October through December. You can go look back and take January, February, March of 2014, April, May, June, July, August, September, or October, November, December. But you will still be required, if you're beyond the first year of attestation and you are attesting in the Medicare system, you will be required to report have a reporting period that corresponds with the quarters of 2014. If you were in Medicaid, no matter what year Medicaid you are in, you will be attesting for any 90-day period. You are not linked into a quarter. It is strictly 90 days. And when I say 90 days, I don't mean 3 months. I mean 90 days. If you are a first-time attester, either Medicare or Medicaid, you will have a 90-day attestation period. Let's talk about those first-time attesters, because I think this has been confusing for people who are coming into the Meaningful Use System EHR Incentive Program for the first time this year. Since CMS had recognized that there were a lot of certification issues going on, CMS had really pushed. It's not a new avenue, but it was really highlighted this year, and that is the concept of a hardship exception. If you knew you were going to have problems with testing because you didn't have the correct technology, you were encouraged to file for a hardship exception to avoid the 2015 penalties that come with not having begun the Meaningful Use Attestation program. So if you were savvy enough to file for a hardship exception to avoid those 2015 penalties, recognizing that you could not attest early, then you would not be grappling with whether or not you'll have a 1% penalty in 2015. The way that CMS works is they have to recalibrate their payment programs on October 1st. They start October 1st for the next year. So October, November, December is kind of puts everything on hold while they decide the fee schedules that people will be paid. So what they were asking is that first-time attesters finish their attestation process no later than October 1st this year. So they would have had to have finished their attestation by September 30th, July, August, and September, and then attest by October 1st. If they had filed the hardship exception, that first-time attester still has until the end of 2014 to do their meaningful use and to receive incentive payments and not to be penalized in 2015. However, if you did not know to file a hardship exception and you are not able to attest by October 1st due to issues with your system or for whatever reason, you can still attest in October, November, and December and receive an incentive payment. And that's important to keep in mind. You are not precluded from attesting if you did not file for a hardship. You will get a 1% penalty in 2015, but you will also be able to get your EHR incentive payment. Let's talk about 2015 because I know this is of concern to the hospitals. As you know, hospitals, you're looking at 2.5 weeks from now, you will be required to move into your next phase of meaningful use. And if you're moving from stage 1 to stage 2, you will have to have all that stage 2 functionality implemented by October 1st. For physicians and EPs, if you are moving to stage 2 in 2015, you will be required, no matter what problems you're having with your vendor, that vendor needs to have that resolved by January 1st of 2015. So hospitals, October 1st of 2014 for the 2015 reporting period. Physicians, EPs, January 1st of 2015 is when you must have all your technical upgrades in place for your next reporting period. Now, whether or not this changes, CMS made a point of saying in the rule that they did not feel that the 2015 reporting period was covered in the scope of this rule. They didn't feel that they had any authority to talk about or to take recommendations on that. So it just remains to be seen if anything else is done about the 2015 reporting period. Let's talk about what it is that CMS is not just proposing, but has put into place for what they're calling the flexible reporting option for meaningful use in 2014. Important to keep in mind, this flexible reporting option only goes to 2014 reporting. It is not being proposed to be used in subsequent years because, as we just spoke about, CMS anticipates that everyone will be on their full 2014 certified program by the time that they begin their next attestation period. But for this year, because of all the vendor issues and functionality and implementation issues, basically what CMS is saying is if you are having problems, we are going to propose different ways that you can report other than what has originally been scheduled. And so they've created what they're calling look-back periods that allows use of earlier measures that hopefully your system will be able to report on. As part of that, the rule changes the requirement that was in place to this point in time that you had to have a fully certified 2014 system in place in order to attest in 2014. This is no longer a requirement for 2014. And it will allow, CMS will allow a look back or a use of the 2011 certified systems or a combination of the 2011 and 2014 certified systems to meet the meaningful use measures in 2014. Okay, well, how do you know what to do? When do you use this flexible reporting option, and what are the various options? And the answer is, straight out of the rule, that your use of the flexible reporting option is determined by what technology you have in place. And to quote the rule, it is the addition of certified EHR technology available to a provider dictates the stage and version of the meaningful use objectives and measures that the provider will be able to meet. So this is really a fact-driven issue. There is no blanket, do this and do that, and this is how you report. This is really fact-driven at the provider's level and at the hospital's level. So you have to do a complete analysis to determine where you're supposed to be and what you're supposed to be reporting for in 2014. Clearly, CMS is trying to make it as easy as possible for as many providers as possible to continue down the attestation pathway and to meet meaningful use this year. But how this works is really important to take a minute, think about, and then plan on how you're going to analyze it. So you always play to the highest level that you can given your technology. Let's look at the actual proposal and how it would work. Let's say most hospitals are not in this boat in the first column on the left-hand side where you're at a fully 2011 certified system. Most of the hospitals either fall into that you have combined 2011, 2014 certified system. If you're modular, it may be that, 3/4 or 90% of your modules are fully certified, but you may have that remaining module that is not. So you fall in that middle column. If you have a fully 2014 certified system in place, so your vendor, if you have one or many, are fully 2014 certified, but for whatever reason, and we'll look at that, what the reasons are, you cannot implement it fully and report on those measures, then you fall into the right-hand column. But especially for the EPs, if you have a system and you've reported on the 2011 system before, 2011 certified system, but your vendor either hasn't been certified, which, as we said, we know there are some out there that haven't finished their certification process, or if they're certified and they haven't given you your upgrade to 2014 at all, so you're basically in your office, you have a completely 2011 certified system, you will definitely fall in the first track. And what that's saying is if you have the same system that you had last year, then you're going to use the same standards you did last year. So you are at the 2013 meaningful use standards, measures, and CQMs. Very important to keep it together as a package. So basically, if you're in this situation, you will test exactly as you did last year. If you are the combination, let's look at some of these slides here. For the 2011, as we said, that left-hand column, what I want to point out here, let me look at the CQMs. Okay, this is the CQMs for that 2013 if you're using a 2011 system. So you use the 2013 measures, but please keep in mind, and I think this is really important to watch this year, CQM issues are probably the #1 single biggest technical issue that has been presented to the vendors and to the practices. If you couple with that the fact that there is increased reporting in the CQM area, it's really important to watch this when you go to a test. So if you're doing the 2013 look back, you will be required to do the mandatory CQMs. So for hospitals, you would be reporting on those 15 required CQMs that were part of the 2011, 2012, and 2013 attestation process. If you are an EP and you've attested before, you will know what I'm talking about, that in 2011, 2012, and 2013, you had a required 3 CQMs that you were required to report on, and then optional 3 CQMs. So you're doing reporting on 6, 3 required, 3 optional, and the required are smoking, I can't even remember all 3 of them, but you know what I'm talking about on the 2013 CQM reporting. If you end up as a stage 1 person and your system, let's go back to this and look. Say you're a stage 1 reporter and a tester on the top line, stage 1 and go across, and you are not fully certified, but you can still report on 2014 stage 1 measures. So this would include your patient portal and include the increased CQM reporting to 9. Then that is exactly what you would do. So let's go back here and look at if you were reporting on 2014 measures for stage 1. So your functionality allows you to report on that in the sense that you have an active portal, you have the ability to track additional CQMs, and that depends on your vendor certification. Then you will be reporting that whole package of 2014 measures, and you will be doing the 9 CQMs if you are an EP. If you are stage 2, or you would have been scheduled for stage 2, as we said, if you are just working with a 2011 certified system, then you will be reporting 2013 measures regardless. If you are partially implemented but not fully implemented on your 2014 system, then that gets a little more interesting about how you analyze it. So let's say that you have received part of your upgrade, but your portal is not active, which is a common factor or a common scenario that we've heard out in the field. So you have received some of your other upgrade or everything else, but the portal just is not working for whatever reason. In that case, because the portal is a requirement for both stage 1 and stage 2 of 2014, you will be looking back and using that 2013 set of measures and CQMs. If in fact, though, you have received your upgrade, your portal is working, but there's issues with, say, transitions of care, which we'll talk about in a minute, then your look back would be to 2014 stage 1. So 2014 stage 1 for stage 2 participants. If you cannot meet or are having problems with functionality and are not fully implemented. So the 2014 look back can be to either 2013 stage 1, 2014 stage 1, or 2014 stage 2 measures if you are scheduled to be in stage 2, depending on the fact pattern of your case. Okay, let's talk about Medicaid. Under the rule, if you're a Medicaid provider, then all the Medicaid programs will be adopting this flexible reporting option as part of their program. But as you know, the Medicaid programs have their own vendors that they use for meaningful use attestation. So those vendors need to basically gear up and be able to handle these various reporting options. And Scott's going to be talking about how you attest given what option you're in. but because Medicaid runs on a different system, it may take the states a little more time to get this set up. I did talk to Ohio this week, and they are working on it, but right now I'm not sure whether their logic allows them to do the fallback right now. We will get a date for you on that. But let's just say for Medicaid, if you are able to report on the 2014 meaningful use measures right now, Medicaid is open and is accepting and has received 2014 attestations. So any issues that they might have is really with the look back and not with 2014 attestations. So if you're doing 2014, either stage 1 or stage 2, Medicaid is open to receive, and you should just keep down the path of doing that attestation. Okay, specific changes in the rules, and I think this is really worth paying attention to because it gets a little bit quirky as to how when you create a look-back period that allows you to attest to an earlier quarter and use earlier measures, how that really works in practice. And clearly one of the areas where it's problematic for Ohio is in the area of public health reporting. Now hospitals, I'll flip over for a second to the hospital stage 2. Hospitals, you will still be required if you're at stage 2. There is no change in the public health reporting, so you will still have your 3 public health reporting measures. You'll have your syndromic, immunization, and ELR. If you're working with the HIE on those, we will continue no matter what your reporting is to get those in place for you. If you're reporting directly and you're at stage 2, you still will be required to meet all the meaningful use criteria of what is active reporting for public health. But let's look at everyone else, especially the EPs, because we are in an unusual situation in Ohio in the sense that in 2011, 2012, and 2013, people who were attesting to meaningful use on the EP side, the immunization program, although it was open, was not open for meaningful use testing. It was, they were setting up, doing actual immunization reporting, but the state of Ohio recommended for EPs that they take an exclusion for immunization reporting rather than trying to set up connections and tests for all the EPs in the state. So jump forward to 2014. The state of Ohio has opened their EP public health immunization testing process. And we will be sending, as part of this webinar, information about how you do that test, screenshots for it, and a little explanation about what ODH asked for to get that done when Dottie will be sending that out with the whole package. So you can look through that for information. But as far as how that affects your attestation, let's run through this if you're using the flexible reporting method. If you need to look back to 2013 standards, or if you're using 2014 stage 1 standards and you are looking back to an earlier quarter this year and trying to report on it, then you're allowed to use a screenshot from an earlier year to meet those meaningful use measures. So for public health reporting, that's the general rule. If you're using the flexible reporting option, you can use a screenshot from a prior year to show that you have met the immunization reporting. But if you have not, are not using the flexible reporting option and planning on attesting this year, or if you did not attest prior to this year, so there was no option for it, you will still have to be able to show that you have that functionality enabled, so you will have to show a test message. We have asked CMS to review that position for Ohio, since Ohio would not have cases where we had screenshots from previous years. So if we get clarification about this, whether or not you continue to use exclusion or whether you could use a screenshot that's developed in, say, September or October this year and you're reporting on January, February, or March, as your reporting period, whether that would be accepted. So stay tuned on that, and we'll let you know about that. And the same thing's true with first-time attesters. You absolutely need to demonstrate that functionality that your system can do immunization reporting. All right, the other big issue on specific meaningful use measures for this year, and this is the one that I would say to everyone, and Scott's going to be running through what are acceptable and what are not acceptable reasons for using the flexible reporting option. And this particular transitions of care measure is really the only measure that gets addressed at a specific level if you are not able to meet it. And the reason why, and many of you have been down this path, so I'm not telling you anything you don't know, and that is that it's been fairly difficult, even at the 10% level, to meet the electronic transitions of care for CCDA documents. So if you're doing, let's back up and look at that measure. If you are at stage 2, you are required to be able to meet a transition of care measure. And that measure has 3 parts. 50% of your patients who transition either through referral or through a transition of care who move to another provider's care, 50% of the time you have to send with them a clinical summary document called a CCDA so that the next provider can adequately care for that person. The second part of the measure is that in 10% of those transitions of care that you participate in the 50%, 10% of those times you need to send that electronically. And the third part of the measure is you need to do a test just to show that your system can send that document. But this particular part of the rule talks only about that second of the 3 prongs of transitions of care. It talks about how you meet the electronic sending of a transition of care document. As many of you have found out, especially if you're with hospitals, that can be an arduous process to say the least, because it requires you to have worked pretty closely with your community in determining if they have direct email access, if they're set up, if their HISP is set up and can receive, and then to do all your test and piloting. So this continues to be, from what we've seen, probably the Achilles heel of the stage 2 reporting, and not because people aren't technically able to do it, but because it takes a community approach. And so what CMS has said, recognizing this, because this was commented on fairly extensively in the rules, is that if for whatever reason, and Scott will cover what the reasons are that you have to document, a partner of yours cannot receive that transition of care document if they are not enabled on HISP to receive direct email. If it's a nursing home and they don't have EHR and they are not part of the HIE, whatever that reason is, then if you cannot meet that transition of care measure, then you will be allowed to revert to stage 1 2014 measures for 2014 attestations only. So basically what your look back would be is you would be required to report on your portal. You would be required to report on your other measures as you did last year, but you would not be required to do the transitions of care as it pertained to the 10% being sent electronically. The last specific measure or issue with reporting before I turn it over to Scott to talk about the audit and the attestation procedures is if you have providers at more than one location. So this is going to be an EP situation. We all grapple with how to handle providers who track through more than one location, or if you're a practice that you internally have more than one location, how do you do that attestation? It's fine if it's a combined system. It's not so fine if you have to work with different systems or different upgrades. So if you are trying to attest for an EP who has less than 50% of their patient encounters at locations where they are fully 2014 certified. So let's say you've received upgrade at one location and that's going great. You've received upgrade at another location and that's not going so great and the functionality is not there. And the place where it is working well has less than 50% of your patient encounters, then in that case, the provider may choose to report at the 2013 or lower 2014 standards and use information from all locations for that reporting period. So less than 50% on 2014 cert, you use all locations, but look back to a preceding reporting set of measures. If your patient encounters are at locations where more than 50% of them are 2014 certified systems, so the upgrade's been successful and you're handling 60% of your patients at that location, and that location has 2014 certification fully functional. In that case, if the other locations are not 2014 fully functional, then you would not be eligible to use the flexible reporting option, but your report would only cover the site where the 2014 certified system is fully functional. So less than 50%, you use all your patient encounter data, but you report at whatever level is appropriate to draw the meaningful use measures for those patients. If you're greater than 50% is 2014 certified, then you report for the 2014 measures, but you only report on the patient encounters where the 2014 certified system is operable. With that, I'm going to turn it over to Scott, who's going to talk about our fun topic. As you know, we're all about audits, so Scott's going to cover both the audits and the attestation process.
Just a quick reminder, if you do have questions, please type your questions down in the Q&A box. At the end, we will review every question and provide answers best we can. So now we're going to take a quick look at the audit issues that this flexible reporting option actually provides. As you know, audits are going to continue. We were kind of hoping we would get a break with this flexible reporting option rule, but it doesn't appear that we will, and lately Ohio is seeing a large number of audits. The rule change does create some unique challenges with regards to the documentation that you must retain to respond to an audit, so we're going to dig into that a little bit. CMS provided very specific language with regards to the allowed reasons for utilizing the rule's flexibility and mentions it multiple times throughout the rule. So this is a statement that providers will be required to attest to when using one of the flexible reporting options in 2014. And this is a direct quote right from the rule language. Providers who choose this option must attest that they are unable to fully implement the 2014 edition certified EHR technology because of issues related to the 2014 edition cert availability delays when they attest to the meaningful use objectives and measures. So let's look at the acceptable reasons for utilizing the flexible reporting option. Besides the lack of 2014 certification by the vendor, CMS has identified the following reasons why a provider or hospital can use another reporting option other than the one that was scheduled for 2014. Clearly, this is the easiest reason to demonstrate the use of this rule, that your EHR vendor did not obtain the 2014 certification in a manner timely enough that you could get the software installed. You can demonstrate this by copies of vendor press releases, a letter from the vendor, or email correspondence, or even a screenshot from the ONC Chapel website, which we're going to look at in a little bit more later. So if you have the 2014 cert software, but you received it late in the year, a provider's inability to fully implement that software based on one or more delays related to the development, certification, testing, or release of the product by the EHR vendor, which affected the affected availability. This is a little more difficult to demonstrate. There's not a lot of guidance from CMS in the rule that constitutes, what is enough time between the delivery of the software and, the actual implementation and training and use. So what I would recommend maintaining is that you document the date of the installation. You kind of document the build process and the date that the build was complete. I would retain a copy of the detailed training and rollout plan, and of course all of this is to show that the build, the training, and the rollout of the software could not be completed in a timely manner, allowing you to use that 2014 certified technology, and that drove your decision to roll back to the 2013 standard or from stage 2 to stage 1. Now, if you've got the software installed, a provider could still use the flexible reporting option if there are delays due to software updates that are either delayed or missing, or you got the software and there was a specific function that the vendor hadn't yet provided but was going to provide in a hot fix or a later release. If the software has, if you're waiting on a patch or an update due to a bug or an application error, then that may be a reason to roll back to the earlier reporting standard, or software that's missing a required component or that creates a safety issue. This is, if you've got a piece of software that's creating a patient safety issue that's a component of the 2014 cert, then by all means that's definitely a good reason to roll back to the earlier standard. Again, for your documentation, you should try to retain or try to obtain a documentation from your vendor that includes a letter. If you are unable to get a letter from your vendor, don't let not having that letter drive your decision to move forward if you don't believe that you can use the 2014 software effectively or safely. But it does, a letter from your vendor does definitely strengthen your body of proof. For this issues around vendor delays or software patches, errors, you may also want to retain a copy of your entry into their ticketing or support system with printouts of the case updates. I would also obtain a screenshot of the actual bug or actual error from the system, and also include with that a narrative describing how that bug creates the patient safety issue. Now, there are some reasons that are not acceptable for utilizing this flexible reporting rule, and if you're audited, CMS has identified these as reasons that are not acceptable and will be immediate audit failure. The first being financial hardship. You can't just say, hey, it was just too darned expensive to move forward and to implement this 2014. That's not an acceptable reason. If you're unable to meet one or two specific meaningful use reporting objectives, again, that is not a reason. So if you're having problems with ERX or you just can't get to the threshold on the clinical summary, those are not reasons for utilizing the flexible reporting rule. Staff changes and turnover, while that does impact many projects, it's not a reason to say, hey, we couldn't get our 2014 software installed. And also, providers in action in purchasing, if you just waited too long or you said, I'm not going to do it, not a reason. That will result in immediate failure, regardless of what supporting documentation you have. So, sorry, I think I went one slide too far. Sorry about that. CMS provides some specific language around how or why this rule can be used, but they're vague with specifics of the documentation necessary to demonstrate proof. I've included a few quotes here directly from the rule, kind of to demonstrate the vagueness of some of the language. Auditors will be provided guidance related to reviewing attestations associated with options using the certified EHR technology. We believe that a case-by-case review will allow us to adequately account for the varied circumstances that may result in a provider selecting a different cert option. And the last one, which I believe has the largest burden of proof, is the referring provider must retain documentation clearly demonstrating that they were unable to meet the 10% threshold on the TOC measure. In my mind, that one has the largest burden of proof. And since we don't really know what items will be audited, where they will focus, we recommend err on the side of caution and make sure that your documentation completely covers the burden of proof. So our recommendations for the documentation you should retain is a narrative that clearly outlines your organization story. I'm really big on narratives when it comes to putting together your audit book. Anytime you have a screenshot, you're including a report, always include a little narrative cover page. It doesn't have to be more than a paragraph or a few lines, but you want to clearly tell your story. If you can get them, a letter from your vendor detailing the certification or other issues is a great means of demonstrating or showing why you had issues. Now, again, the vendor letter is not a requirement, but it definitely strengthens your argument and your body of evidence. But again, if you don't get that letter, don't let the lack of a letter be the deciding factor. Now, if you're rolling back to software creating a patient safety issue, you're going to want to get screenshots of that error bug and get if there's a case was entered into your vendor support system, print out that case, print out all the updates from that case, any correspondence with the vendor. If you can get a statement from your vendor, great. And definitely include a narrative providing the background on what your organization did in an attempt to resolve that problem. Now, if you're rolling back from the 2014 standard to the 2013 standard based on the inability to meet the 10% transition of care, again, I feel that this one has the biggest burden of proof. You're going to need statements from the potential receiving hospital or providers, letters from all the sites saying that they're not technically capable of receiving a transition of care. Now, also, if you're rolling back and you've performed your immunization registry test in the previous year or any of your public health tests in a previous year, you're going to want to retain those screenshots and include them in your audit book for this year. So what we're going to look at now is really not the attestation process. We're going to talk about the process, but we're going to look at the pre-attestation process. When you're going through the attestation process in the CMS registration and attestation portal, the selection of the 2011 or 2014 Meaningful Use Standard is going to be driven by the certification number, the certification ID that's provided to you in what we call the CHAPL website, which is really the Certified Health IT Product List, and I've included the URL there on the screen. There's actually logic built into that certification ID number. So we're going to run through this process here in a second, but just to kind of give you a little bit of background, what they're going to do is when you're going through the CHAPL website, if all the items you include are 2011 certified, and you get your ID number, you start the attestation process, it's going to drive you right down that path. If everything you have is 2014 certified, it's going to drive you down the 2014 path. If you have a mix of 2011 and 2014 certified products, when you get your certification ID number, you're going to have an optional path. When you enter that number, it's going to say you're going to get several options on your measures after that. We don't know exactly what it's going to look like, but we've been told that's how the process is going to work. So we're going to run through a quick demo of the CHAPL website, and in the demo, we're going to assume that the organization started the reporting period on the 2011 certified version of Paragon. And then sometime during the reporting period, they got their upgrade in place and they rolled out the 2014 version. So we're going to have a mix. So we would go to the CHAPL website. We are going to, just so you know, this is not we're not actually running through the demo. I built this with some screenshots. So as we go along, you'll see that I'll try to point out the button you should click on. So since we're going to go with Paragon and it's a mix of 2011, 2014, we're going to click here on the middle button, which takes us to the combination. This is an inpatient system, so we'll be clicking on the inpatient practice type. If you're using some ambulatory EHR, you would just click over here on the ambulatory practice type button. So I click on the inpatient button. It takes me to the search option. I'm going to enter Paragon in my search for under product name. Do not just click enter here. You actually want to click the search button. If you just hit enter, it's not going to return anything. You click the search button, it's going to return all of the Paragon products. So we're going to start with, I'm going to select the complete EHR certified version, version 11. I'll go out here and I'll click on the add to cart button. When I do, normally if this were any other year, it was 2012, 2011, I would be done. I would just go up here and click on the Get CMS EHR Certification ID, and boom, I would be done because I've got a complete EHR. And I'm covering all of the general and inpatient criteria, as you can see here, are in blue, which means I'm complete, I can move on. Well, not this year. This year, remember I started on 2011, I'm moving to a 2014 certified version. So I'm going to click to this Return to Search Options button. When I do, I get my search list returned again, and you'll see here next to the red arrow, the version 11 is already in my cart. So I'm going to go ahead and add the version 12 to my cart. When I do, I've got both products now, and I can click my certification, Get CMS Certification ID button. Now when I do, I'm going to want to print this out. I want to keep this in my audit book. But it's this number now has logic built into it that says, hey, this is a mix of the Paragon Complete EHRs. I'm going to use that number at the beginning of the attestation process. It's going to drive me down the path of giving me options of how I want to report. So one thing we think it's important to include some comments from other organizations. When the proposed rule was released, there were a large number of comments and press releases from different organizations, vendors, and providers. Then CMS, had the mandatory 60-day comment period, and some organizations openly shared their comments that they submitted. And then, as you can imagine, when the final rule did come out, it resulted in a large number of comments, again, from different healthcare organizations and vendors and providers. So we feel it's important to share some of these comments. Chime stated that they were deeply disappointed in the decision by CMS and ONC to require a full-year reporting period for 2015. This provision has severely muted the positive impacts of this rule. Further, it has all but ensured that the industry struggles will continue well beyond 2014. Then MGMA stated while they appreciate the rule's focus on the certified EHR software, many of the prevailing issues with the meaningful use program are not addressed. Specifically, he said the rule ignores some of the new meaningful use requirements, have proven to be extremely onerous, and forced eligible providers to rely on the actions of third parties. He's speaking about the transitions of care and the patient portal measures. And John Halamka, the CIO of Beth Israel, this is the quote that, for me, it resounded most with me. He said, although certified products have been introduced into the marketplace, the time to implement, train, and ensure safe use exceeded the stage 2 time limits. And the reason I like this statement is because it's focused on what's most important, patient care. So I'm going to turn it back over to Kathy, and she's going to talk about some of the other issues that were addressed in this rule.
Okay, just really quickly, I want you to be aware of what else the rule covered. Most of this is stuff you will be familiar with, but it finalizes and makes official areas that have been talked about over the past 2 years. First of all, the rule officially extends Stage 2 to include 2016, so Stage 3 begins in 2017. And we all had heard Dr. Mostashari talk about that before he left. It also officially finalizes the alternate measure for Stage 2 hospitals on sending lab results to their ambulatory practices. When the rule was first put out, the meaningful use measure, it required the hospital lab to have received the report electronically, and then and only then would account for electronic submission back to the vendor. That has been changed, and actually this was proposed in 2012, late 2012. So my guess is that all the hospital vendors have built to this change already. But now when you calculate your lab transmissions back to your ambulatory vendor, you count it regardless of how the original order was received. As far as the patient portal measure, again, this is an EH correction and not an EP one. Apparently, CMS had it was an oversight, has limited now the view, download, and transmit to unique patients seen rather than all patient encounters for the patient portal. And that's just in case you have providers, or not providers, patients who come back through more than once, you're still just going to be counted once as a unique patient for view, download, and transmit. And then there were a number of technical areas involving CQM reporting that really don't affect people as a whole, but are more vendor issues. This last one is a hospital CAH issue. You all should have already been aware of this. It's been out there as an FAQ through CMS for, I'd say, at least a year. But again, it's being finalized as part of the Meaningful Use 2014 attestation, and that is hospitals with 5 or fewer discharges during the reporting period. So this year, that's by quarter, or 20 or fewer in a year's time, can claim an exemption for that CQM report. But in order to claim the exemption, the hospitals must submit aggregate population and sample size counts as part of their attestation process. So again, specific to CAHs, well, it's not specific to CAHs, but they're the most affected by this. Please review that. As I said, there are FAQs about that if you need help with that. Let's just do a very quick recap so you have a flow sheet when you go to look at your own situations. Very first thing you do is determine what the status is of your EHR system. Is the certification complete for 2014 or not? If the certification is complete, are you fully functional? Have you received all your upgrades? Are you completely trained and able to use the system? Depending on your answers to that first bullet, you then determine what your reporting options are. Are you going to report at stage 1 in 2013 measures from last year, duplicate of last year's reporting, or are you going to move ahead and use your portal measure if your portal's functional, or actually go ahead to stage 2 if you're required to do that? As part of that analysis, you then have to look at what CQMs you're going to be reporting and keep the CQMs completely in sync with the meaningful use measures that you're reporting. So 2013 measures, you're reporting 6 for the physicians and 15 for the hospitals. If you're using 2014 measures, you're going to be doing 9 CQMs for the EPs and 16 for the hospitals. Go to the Chapel website or ask your vendor if you're using just a single vendor. Determine what your CMS certification number is, and then use that to begin your attestation process, and that will put you in the correct path for attestation. And then lastly, please maintain all the documentation needed to show why you have attested the way you have this year. So in case of a later audit, you were able to show what your procedures were. Final thought, and I hate to think that anyone will need this, but being realistic, I'm sure there are people that fall into this boat. If for whatever reason you are not able to attest in 2014, so you're not able to attest at all, a flexible reporting option, otherwise you're a new attester and haven't received your system or whatever, make sure that you're looking ahead to filing your hardship exceptions so that you avoid your penalty in 2016. And for EHs, you are required to file that by April 1st of 2015, and for EPs, you'd be required to file by July 1st of 2015. But that is only if you have not been able to attest come the end of your reporting period in 2014. So with that, I think we're going to turn it back over to Scott and then go with any questions.
All right. Just real quickly, here at the Ohio Health Information Partnership, we do have a service line that we refer to as CliniSync Plus. It's focused on meaningful use, both Stage 1 and Stage 2 support for the various meaningful use objectives and CQMs. We provide guidance on shaping your meaningful use adoption strategy timelines. The service line includes monthly monitoring, review, and discussion of your meaningful use reports. We do also provide audit response support and perform mock audits and some guidance on aligning the clinical quality measures with your other quality programs, including PQRI and IQR. And again, you can find out more information about that at the CliniSync website. So we are going to roll right into the questions. Give me a second here. We're going to go ahead and open up our question screen. There's still time, definitely still time to enter your questions down there, but we are going to run right down through them now. Okay, the first question says, what should an EP do or document in the case that 90+% of the providers you refer to cannot receive your CCDA for reasons not due to certified EHR availability delays? For example, they just aren't doing meaningful use, they decided it was too expensive, they delayed their upgrade intentionally, or have other reasons specifically excluded from the flexible reporting option.
Okay, Ron, excellent question. I guess actually that's Lindsay. The rule doesn't talk in terms of if it's a non-technical issue, but I would say that's a, quote, functionality issue in the sense that your receiving provider is not able to participate because, technically speaking, they don't have the HISP and they aren't part of the direct email, which is how in Ohio the vast majority of transitions of care are being handled. So for me, that becomes, you describe it in terms of a technical issue, and then you document that your referral patterns are to these physicians, and when you print out your create your summary of care documents, you have a list of the providers that those go to, and then just attached to that list whether or not that particular provider has a direct email address, which is the technical reason why you cannot send it.
Okay, next question. Can you review the immunization reporting information one more time?
Hey, Jill, no problem. I'm sure we'll be going through this again, but right now we're kind of in a limbo. ONC has agreed to try to expedite the question out of Ohio, but under the rule, if you in fact have a screenshot, and as I said, this is primarily EPs we're talking about because it was them that had the immunization requirement in Ohio for public health reporting. So if you are a new attester, or if you are attesting according to the timelines that you were supposed to be in 2014, then you are required to have a screenshot, because starting in 2014, Ohio required you to move ahead with your immunization testing and sending transmissions. So if you're new, or if you're keeping your same standards that you would have been required to attest this year if we hadn't gotten into issues of certification, then you should plan on going ahead and doing your meaningful use test with Impact SIS, which is the immunization program with the Ohio Department of Health. We will be sending, as part of this training, 2 sheets, one with screenshots on how to do the test and one with information on how to register with the Ohio Department of Health. This is a separate issue than if you're at stage 2. At stage 2, you have to be ready to actually do the transmission, and so the registration includes stage 2. But if in fact you are using this reporting option and moving back to 2013, we're asking for a clarification about what you'd have to show for immunization tests, because you may well be using an earlier quarter or 90-day period earlier in the year when you didn't know that you were going to need that screenshot and that test, and so you haven't done it. So as soon as we get clarification on that, I am sure we will pass it out as quickly as we can.
Next question. I have an EHR that wasn't certified for 2014 until July of this year. Can I attest to stage 1, year 3 under the Ohio Medicaid using Q1, January to March, data under stage 1 criteria, since all I had during this quarter was the non-2014 certified version?
Okay, this gets into more of a fact pattern, and let's see, you received it in July. What I would say, you've got to develop your fact pattern here. If you received it in July, you have the option certainly of attesting later in 2014, but it may be that it's not fully functional or you've had problems getting the functionality, and you decide to look back and report on an earlier period in 2014. And I would say that would be fine, but if you've received it in 2014 in July, and you have the option, because Medicaid allows you to run it separate from the quarters at any 90-day period, and you get that functionality up and running, say, by August, you still have time to attest in the 2014 standards. So it really becomes a fact-driven pattern, and you just have to see how long it takes to get the functionality and how much time you have prior to a reporting period to get all that up and running. And it's a little bit harder with Medicare, because you're locked into just 4 specific dates when you could have started your attestation. So if you're July and you're still having problems in September, then clearly, you're locked into that reporting period. But, with Medicaid, a little bit more flexible, but still the same issues pertain. If you don't feel that you're comfortable with your system, it's not running completely, you're having problems with your portal or something, then I would think that the look back would be appropriate.
Okay, next question. This one's a little bit lengthy. If an EP has a 2014 version certified technology with a clear software error that prevents meeting the MU2 measure, is there any guidance on the timeframes associated with the vendor fixing that error and the EP using the flexible reporting options? For example, my client has a technological issue currently with their summaries of care, and we have no idea when the vendor will fix it. Could they still claim the flexible reporting option if the vendor fixes it on September 30th or October 15th?
Yeah, I would say without a doubt you can use it in this case. These are exactly the issues that CMS was trying to address, where the uncertainty with the vendor's actions, whether or not the vendor is able to fix it on the 12th hour, so to speak, is not important here. What's important is the fact that they haven't been able to fix it, that there's uncertainty in your ability to attest, and you need to be able to plan. And that's a huge issue for all of you out there, is the planning issue. So the vendor may be able to fix that close to the start of the attestation period, but you're going to have problems getting your people trained or getting your transitions of care and your referring patterns set. And so in that case, I would say absolutely this is one of those situations where you would be interested in using the flexible reporting option and looking at a prior quarter or 90 days to use.
And the lack of training, the lack of training can definitely create a patient safety issue. So I would, accompany with your documentation a nice narrative saying, here's what we tried to do. We couldn't train. We couldn't do X, Y, and Z. Retain any correspondence with your vendor that you've had around the bugs and the errors and whatnot. Definitely want to build your case, but I definitely feel that is a strong reason to roll back. All right, next question. So if we determine our software is not ready, we can jump back and report on any previous quarter of the year. That is correct. If we jump back, does the security audit have to be done in the quarter we attested for, or can we do that in this quarter and report on numbers from a previous quarter?
Gosh, Joel, you must have been sitting in our office yesterday. We actually had this discussion with Ankh, And that too, we sent up several specific questions related to the flexible reporting and how you do timeline issues that relate to what should have been your reporting quarter or 90 days. And those issues that we identified were the immunization test. That's number one. Number two is functionality shots, clinical decision support shots, and the last one, which I think is significant, is privacy and security. And so these questions were all sent up to CMS via ONC for answering, to explain whether or not, if you're using a preceding quarter or 90 days and you do not have documentation of these things because you were not planning to use that as your attestation period, if in fact you can either do your immunization testing or run your privacy and security report real time and have it completed before the end of the calendar year and before you attest, and still have it count. So again, hold that thought. Excellent question. I'm sure other people across the country are asking it, and I'm sure CMS will move very quickly to clarify that. We will send out to everyone any FAQs or information that we receive back to make sure that you understand completely how to use this flexible reporting option.
And prior to the release of this flexible reporting rule, we had internally had felt that the security audit was going to be an area of focus due to the increased requirements of the security audit for 2014. So we are definitely going to follow up on that. If you've not done your security review, please make sure that you meet the requirements of the new security review standard. All right, next question. We got a scenario. A hospital's at stage 2 now, but could not fully implement the 2014 certified software in a time to fully meet all the requirements. They will use the 2014 certification number, but want to fall back to stage 1. How will this be addressed during the attestation process? From your example, it would seem that the selection of 2014 software will drive the hospital to stage 2 on the attestation website.
Not necessarily. I agree that it will keep you in the 2014 queue, but the only time that you have no option is if you're saying that you're 2011 certified, in which case it will only give you the option of going to 2013 measures. If you're a combination of 2011, 2014, or you're 2014, then it will ask, the logic will come up, put you in that column, but in both cases you have a question, or you have an option of which reporting you're going to do, whether you're doing stage 1 or stage 2 if you're fully 2014 certified, or rather if you're a combination 2013, 2014 stage 1 or 2014 stage 2. So that you'll see that in that logic when it comes up, but as far as the rule goes, yes, you do have that fallback. You can do it, and again, it's just a documentation issue.
Okay, next question. Any thoughts on how to get patients to participate in using the portals? Practices with large Medicare populations are having difficulty meeting the 5% threshold.
Okay, we've been working with groups on a number of different issues, and the thing about stage 2 is look at all your measures together, see what your objectives are that you're trying to meet, and then see where you can use like issues to support your reporting. The question of, let's take this as a two-parter, question of a large Medicare population. Clearly, you have to have someone in the practice who's working with patients and coming in with a laptop or a tablet and showing them the website and stuff. With their approval, you can ask for a family member who can actually monitor the portal for them. You just have to make sure you have the consent for that. So that's number one. The Medicare issue is always a little bit touchier when you have an older population, but actually their interest level is higher than almost anybody else's on use of portal. The second thing, the question of how you integrate your stage 2 measures and how you can use one to drive the other is CQM reporting. If you put flu vaccine on as one of your CQM measures that you're going to track, then work with your vendor to see how you can do a blast email through your portal about flu vaccines. So that meets your measure for patient education for the reporting period. The second part of that is if you set it up, and we've seen some accounts have been very interesting in how they've done this. If your portal can hook back in and allow the patient to respond, which they should under their 2014 certification, set it up that, hey, you know, this is beginning of flu season. Just want you to know that we're opening for flu immunizations, and we just want to make sure we have enough flu vaccine for you. So please let us know if you're interested in receiving the flu vaccine, and we'll make sure that we get you scheduled for it. And then you give them options of, yes, I am interested in being scheduled. No, I'm not going to get one. I have already had one, and date and time. You know, please contact me for more information. So you have hit a home run in this area because you have you have received your information for your CQM, and if they have identified that they've received it someplace else that meets for that CQM, you have met your patient reminder, and you have also you know, had a much better possibility of getting your 5% on the view, download, and transmit, where the patient sends back, and the secure messaging, where they have to also send back a comment to you.
And another thing you can do too is at every opportunity that you have, drive the patients to the portal. You know, most of the patient portals out there will allow for a refill request to be sent through the portal. That should count as a message going back to the provider from the patient, because it is a clinically relevant message. So, you know, as you know, work with the folks who answer your phone to say, you know, when they're getting those refill requests, say, you know, to the patient, hey, you know, you can avoid being on hold and waiting in the phone queue if you just go to our portal and you can submit your refill request through there.
Yeah, and another way that I've seen that's been a very successful one for some of the hospitals and practices is you show them the summary while they're in the office, and you're saying, look, you know, we have information about your family history and everything else. Can you do us a favor when you get home, open the portal and review that, because we just want to make sure it's as accurate as possible. And since this is the first time you'll be seeing it, could you go back in and look at it and let us know if you have any corrections? And then again, have a button that says, yes, I have a correction, you know, please contact me, or here's my correction. No, I don't have any, you know, everything looks okay. And have that sent back, and that becomes, again, part of your 5% messaging. So just be creative about what you're asking the patient to respond to.
And for hospitals, you know, integrate the demonstration of the patient portal into your help me out here, Kathy. Words are escaping me. To your discharge process. I'm sorry. These 8 o'clock webinars. So integrate it into your discharge process. Also integrate it if you're really struggling to meet that measure. If you have an associated patient practice, if you're a hospital, again, this is a hospital scenario. If you have an associated patient practice, you can follow up with them when they come for their return appointment to their provider as well, and say, hey, we really want you to log on to the portal. You know, take every patient touch opportunity to get the patients on your portal.
Yeah, if you're seeing them less than or more than once during the 3-month period, just open the portal when they come back and work with them then and show them what's in the portal. And again, you'll meet the measure.
Okay, we've got one last question. Still time to enter your questions real quickly, but let's go. We'll jump right on this last question. If you are upgraded to the 2014 edition certified EHR prior to the start of the reporting period, but there are issues with the portal and configuration that prevent it from being fully implemented, would you use the 2011 certified version when creating your EHR certification on the Chapel website?
I'd use the 2011-2014 combined one because it gives you the same options to report. You can still report on your 2013 measure, but basically what you're saying is you have some functionality but not all. And that then will give you, as I said, the options, 2013 or 2014.
that wraps up our last question.
And with that, what we will do is let Scott go and get his coffee. And seriously, Dottie will be sending you everything. Feel free to contact us. I know this is a real difficult area, and if we can give you any guidance, and please, please watch Dottie's newsletter, and we will send out to everyone who participated any answers that we get back from ONC and CMS about these questions of how you use the look back if it's an earlier 90-day period that you're reporting on.
Again, our contact information is there on the screen. Don't hesitate to contact us if you have any questions, you're struggling. We're here to help you.
Thanks all.
Yeah, thank
Have
everybody.
a good one.